Today I'll be discussing with you a very simple topic, fibroids and fertility. What is the aim when we see a patient who is infertile and has got fibroids? The question that comes into each gynecologist's mind is, should this fibroid be removed or should we leave it behind? I would like to start by telling you what are the hard facts about fibroid. We all know it is the commonest benign tumor which affects the female genital tract. It is seen in about 20 to 40% of women in the reproductive age group, and majority of patients are asymptomatic. That is, on a routine ultrasound examination, we find that she has a fibroid. But the most important point that we all need to remember, that fibroid alone, being responsible for infertility, occurs in only 2 to 3% of all cases. The classification is submucous, intramural and subserosal. The submucous fibroid is further classified as type 0 when it is pedunculated, type 1 when it is sessile with less than 50% intramural, and if the intramural component is more than 50%, it is referred to as type 2. The intramural fibroids do not distort the cavity. That's one classification. And the second classification is that if less than 50% of it is serosal. Subserosal fibroids, when more than 50% of the fibroid is protruding out of the serosal surface. And the other thing we mention is whether it is sessile or pedunculated. What really affects us with the fibroid? It's when they come to us with gynecological problems like pain abdomen, dysfunctional uterine bleeding or urinary tract infections, when they come to us with reproductive problems which includes infertility or recurrent pregnancy loss, or when they're pregnant with a fibroid where they have increased chances of miscarriage, or where they come to us prior to conception. And the group D, which is important to us, is prior to an IVF, where we need to see what is the number of myomas, what is the size of the myoma and what is the location of the myoma. Coming to the adverse effects of fibroid on pregnancy. It is a known fact that fibroid causes spontaneous miscarriage, leads to malpresentations, increased incidence of cesarean sections and preterm delivery. The adverse outcomes always increase with submucous fibroids, fibroids which are very adjacent to the placental surface, as it causes abruption and the premature rupture of membranes, and fibroids which distort the cavity. How does the fibroid affect the reproductive function? It displaces the cervix. As a result, the sperm is not able to travel up. It may deform the whole of the uterus, which tends to impede the sperm transport. It obstructs the proximal fallopian tube leading on to the blocks. It alters the tubo-ovarian anatomy. It is known to cause endometrial changes as well as vascular alterations. Endometrial inflammation and anovulatory cycles are far more frequent with fibroids. Important thing again, I would like to emphasize that fibroid may not be the sole cause of infertility. Thus, before blaming a fibroid, we need to investigate all of the causes of infertility in both the partners. The basic workup as far as fibroid is concerned, the first line is a 2D ultrasound. This helps us to know the number of the fibroid, the location and the size of the fibroid. And it has a very high sensitivity of about 90 to 100% and specificity of as high as 81 to 93%. As far as MRI is concerned, the role of MRI is only defined when the number of fibroids is more than 5 and when we are not able to discriminate whether it's an adenomyoma or it is a fibroid. As far as intrauterine lesions are concerned, transvaginal ultrasound along with saline infusion sonography, that is with ICIs, is considered to be the gold standard for evaluating intrauterine lesions. The reasons are that it's highly sensitive to identify the intrauterine lesions. The results correlate very well with the hysteroscopic findings, and most importantly, it is non-invasive. Thus, if you look at the evidence, what does the evidence really tell us? The evidence tells us that the fibroids which interfere with infertility, if you go with the decreasing order, submucous the most, intramural the next, and the least is the subserosal. Removal of submucous fibroid should be done irrespective of its size because it benefits the success rate of pregnancy. Subserosal fibroids do not need to be removed because they do not interfere with the infertility. Thus, the problem lies only with the intramural fibroids. The impact of the intramural fibroid on fertility is controversial, and the results of therapy are still unclear. But what is universally agreed upon? Any fibroid intramural more than 5 centimeters needs to be removed. Any fibroid which distorts the cavity needs to be removed. What is the role of the expectant management? Expectant management in cases with small asymptomatic intramural fibroids which do not distort the cavity and in subserosal fibroids. There is no role of medical management in fibroids with infertility. Only indication of giving injections, that's GnRH analogues, is when we are removing a submucosal fibroid by hysteroscopy. Surgical methods can be laparotomy, laparoscopy or hysteroscopy. It depends upon the size, the number, the location, the expertise, the equipment that is available. As far as the hysteroscopic myomectomy is concerned, it is done in intracavitary, that is type 1 as well as type 0 fibroids. Patient has to be counseled about the risk of perforation and the possible effects on the pregnancy and fertility before we take the patient for that surgery. As far as the Cochrane review is concerned, it says that there is very limited evidence to suggest any difference in fertility rates whether the fibroid is removed laparoscopically or by laparotomy, but you would all agree that laparoscopy is beneficial because it is associated with short stay, early recovery, less chance of postoperative adhesions and less blood loss. What is the role of GnRH analogues before going in for surgery? The advantage is that if a patient is highly anemic, we get time to build up the hemoglobin. It is known to decrease the blood loss, but though not many surgeons agree to it, and it is beneficial in hysteroscopic myomectomy. But the disadvantage is that all the laparoscopic surgeons universally agree that when the patient has received GnRH analogues, there is a loss of planes, as a result of which myomectomy becomes a little more difficult. If you look at the success rates after having removed the fibroid, there is a marked relief of symptoms in the patients who are symptomatic. Pregnancy rate improves to about 40 to 50%, and majority of pregnancies we have noticed, if they occur in the first year after myomectomy. And the miscarriage rate too is significantly decreased to as low as 41%. Coming to the other modality, that's uterine artery embolization. All the bodies, whether it's ACOG or RCOG, they say that if it is to be done, it is to be done as a last resort in a patient who cannot undergo either myomectomy or it cannot undergo either hysteroscopic or laparoscopic. In such patients only, after explaining to them the controversial role of UAE, can we offer UAE to such patients. Thus, the recommendations at present is that women with asymptomatic fibroids should not postpone pregnancy, since fibroids combined with advanced maternal age can lead on to greater infertility. In women who are planning pregnancy, prophylactic myomectomy should not be done to prevent pregnancy complications. Myomectomy is only to be considered after both the partners have been thoroughly investigated and we know that fibroid itself is the sole cause of infertility. Submucous and large myomas should be removed. Small myomas and subserosal fibroids need not be removed. There is no role of medical management. UAE MRI guided ultrasonic treatment is still not recommended, and preoperative GnRH only to be given to anemic patients or the one undergoing hysteroscopic myomectomy. I would like to end by only telling each one of you, whenever in doubt whether to operate or not to operate, do not hesitate. Please ring up an IVF specialist and take an opinion. Patient is of prime importance to each one of us. Thank you.